So, this past year I spent a lot of time with the quality assurance expert at the National Surgical Hospital in Vietnam, mapping between the Vietnamese procedure coding system and the ICD9 system for Vietnam's DRG. So the previous mapping was 50% wrong, and so it was really important that we went through this validation process, and it took a lot of time because everything was in Vietnamese and English, so it was not as easy as here where everything is in English. So it took us a year. So we're very ambitious to think we can validate the whole thing in 1 week. We can make a lot of efforts to do that, and I know that there was already a lot of effort made into mapping the system. But it's going to require many different minds working together to notice that something seems a little bit off. But I just, ICD9, I've become very familiar with the structure, but RBS is new to me, so I'm not as familiar with RBS because I haven't used that system. So please, if I misunderstand something, please correct me as we go along. So the ICD9 CM is actually not part of the WHO. So many people misunderstand that ICD-10 is WHO and ICD-9 is WHO. It's not. WHO did not initially put together a procedure coding system. So countries like the United States and other countries needed a system to classify procedures as well. So in the United States, they developed the ICD-9, which was accompanying ICD-9 disease code. And it was a way that they could better manage the health system by classifying procedures into similar categories. So it was done by the United States Centers for Medicare and Medicaid Services. I just want you to understand the origin is from the United States, but at the same time, it is used currently in many countries. So in Thailand, they're using it for the primary coding of procedures. In Indonesia, also they're using ICD-9 coding system. Vietnam is trying to map between Vietnamese procedure and ICD-9, and may eventually choose to adopt ICD-9. I think China also is using ICD-9 because they need it for their papers as well. And I think PhilHealth currently is using RPS, we map to ICD-9, but maybe in the future, as the primary procedure coding system or another system.
Wala man lang presenter.
Not only used by the US.
Yun yung tanong sa chat kanina wala bang PowerPoint? Yan. Ano yung ginawa mo? Hindi, wala naman po. Yan. Ngayon lang siya nag-start.
The distinction that I want to make is many countries, they're starting with the per-service payment system. So for each procedure that they have a name for each procedure and the price attached to each procedure.
Kasi ayaw yung ating
Yes, used in the per-service system. So ICD-9-CM is a classification system. So it's not a procedure list. What it is doing is it's classifying similar procedures together. So it's normal that you would have 2 or 3 procedure names that will fit into the same category. So it's important to understand. I think RBS is more of a procedure list used for payments. And what we're doing in the mapping is partially we're grouping already into classes of procedures as part of this. Many similar RBS procedures will map to the same ICD-9 code, and that's expected and normal. Another thing to understand is that RBS may be missing certain codes. You have hospitals saying, what our procedure, we're doing this new procedure, it's not on the RBS list. We need a new code. So the ICD-9 system is a classification system. You have unspecified, you have other. So you can have, spinal procedure, and then you can have other spinal procedure. That means anyone that's not yet listed above, it still fits in the classification. So the classification system is also helpful to fight back against hospitals who will try to add more and more procedures to say my procedure is different. But you can always find a way to fit it into a classification system when you have unspecified or other categories. And of course, I think you have in your claims review system, patients can have at the same episode of care multiple procedures. And in such cases, you would give multiple procedure codes. So that's also very normal for a health system, an IT system, that whenever a patient is discharged, you would list all of the procedures that were performed for the patient. Thank you. So you studied ICD-10 coding system. So you understand the body system structure of the coding system. So the ICD9 system also follows this basic body system structure. But within the details of the coding system, you have some ways of classifying that are based on further detailed body parts. So for example, the ear, you have the external ear, the middle ear, and the inner ear. On the musculoskeletal system, you would have facial bones is one subchapter. And then you would have other kinds of bones, but procedures, or then spine, and then maybe joints, and then muscles. So you can have different categories that are related to different body parts. So this is done organically. I mean, when they developing the system, they said, oh, the way we think about it is that we think about the external ear and the middle and inner ear. So let's categorize this way. But sometimes the categorization is based on type of procedure. And this is, I think, RBS is very much is this combination. You have some that are the body part or the body system, and then you have incisions, and then you have excisions, and then you have insertions or introduction, I think we call them in RBS. So you have these different types of procedures. So when I was learning about ICD9 in the past year, I was also a bit confused sometimes because some of the names are similar and I was not so familiar. So, for example, many of the procedures have the name otomy and ostomy. And sometimes when I look on the internet to find out what is the definition, when I search otomy, it comes up ostomy. So I think that maybe there's also confusion within the clinical field. And maybe sometimes the difference is not very important. So among the doctors here, what is the difference between an otomy and an ostomy? So what is an otomy? When you think of a type of cavity, craniotomy. So what is otomy? It's an incision, right? It's an incision into. So whenever you see the term otomy, you can think immediately it's an incision. So it may be a craniotomy. Crane is the spine, the skull. So craniotomy is incision into the skull. But if you see otomy for other body parts, you would also know that this is an incision. Sometimes otomy is used for drainage. Sometimes it's used for access, for surgical access of another part of the body. It can be used to access to get a biopsy or something. So we know that now otomy. What is ostomy? Pardon? So the ostomy, can you think of examples of ostomy that you hear about in everyday life? Colostomy. Yeah. Tracheostomy, very good one. Colostomy, colostomy. So there are many types. And I think that it's important that when you're reading through and you see the word ostomy, that you distinguish from otomy and you know these are two different things. So that you can make sure to group in the right category. Or revision. So in Vietnam, it was very funny when they translate the term revision in the surgical term revision as like to review for an exam, because that's how they understood what revision is in English. But surgical revision is when you're redoing something that usually is an implant. You do an implant of the hip. And it fails, and you have to do a revision of the hip replacement. So revision is one that sometimes in the non-medical field you think it means something, but in the medical field it means something else. So anytime you see revision, usually it's related to implants, but it could also be related to just redo the surgery that failed. Division. It was really confusing to me because it sometimes means that you're splitting something, like you're splitting a nerve. But division can also mean to destroy. It can mean destruction. So sometimes nerve division is done so that you destroy the nerve so there's no sensation anymore. So that was one that I think non-surgical people would think it's very normal. You think it's splitting something into two pieces. So this may actually create destruction as well.
a reduction. And also in Vietnam, it was very strange because they know the term for setting a bone, but to call it a reduction, it was kind of strange. And then we find that reduction is not only used for bones, but also used for other things where the body part is in a torsion, and then moving it back to its normal position would be a reduction. So I think it's, for non-medical people, it's important to understand that term. What is the difference between the ligation and occlusion and embolization? Because you see all of these terms, and sometimes it's confusing are they the same thing? Because they're basically serving a similar purpose, but they're done in a different approach. So these were terms also that we found in Vietnam was very hard to translate because the term in Vietnamese was the same for all of them. And so trying to find a different way to explain the different ones was problematic. And they tend to be used differently. Like tubal ligation is often used in gynecology, but then you can also have ligation with blood vessels. So understanding the generic term, what it means, is important. So I don't know if you have received the documents, but the document that I sent to you, I actually derived from a later version of ICD procedure code from the US. So this is a document that I gave you as a, is that big enough? So I tried to create this document, and I'll have a Vietnamese version if anybody's interested, to try to understand the other terms used for similar procedures. So sometimes in one body part they call it one thing, and the other body part they call it something else. And so sometimes it can be confusing. And also difference, what is a resection? Resection surgery, how is that different from an excision surgery? So this is something for you to look at when you are going through the ICD9 codes and you're not sure about the term, and is it different with another type of term? So I don't expect to go through this today in the class, but it's a document for you to use as a reference if you find a term and you're not sure how to understand it. There's some distinctions that are made in the map, in the coding system, that we also found that when they did the initial mapping in Vietnam, they coded some things that were a surgery as a procedure and others as a procedure when it was when it was a procedure, it should be coded as a procedure, but they coded it as a surgery. So distinctions between, for example, open versus laparoscopic or endoscopic. And if it's done, for example, with the heart, they can do catheterization endovascularly, or they can do it as an open surgery. So there are things like valve replacement or valve repairs. There is an open procedure, which it can be very dangerous for the patient. They keep the patient for a long time. It can be more expensive. And then you have the endovascular approach. They can discharge the same day. So these distinctions are really important in the ICD9 system. And also for the IG, whether it's the first time it's done or it's a revision. So the revision of a hip, the hip replacement, the revision requires that you have to then remove the piece that you put in and put a new one, and they can relate to cracks and fractures within the structures surrounding the implant. So first time versus revision, not all cases, but in some cases that distinction is important. Again, endovascular, percutaneous, transluminal. So these terms, sometimes they are distinguishing between one procedure and the next procedure. So we should always pay attention to all the details in the name of the procedure. Surgical approaches, sometimes you can do an anterior approach for a spinal fusion, or you can do a posterior approach for the spinal fusion. And those may also be important distinctions for the surgeons. Grafts also was something that we found really confusing in Vietnamese, because you have different kinds of graft. But graft generally is the living tissue. So it's still alive, it's not a synthetic tissue.
And if you use synthetic, usually the term used is implant. So you can distinguish between those, but usually there will be additional information to know, is it autologous or autograft or allograft, or in Vietnam they still use homograft or heterograft. So these kinds of distinctions may maybe not in the main code name, but in the additional information that helps you to know which category to put in. Another important thing that ICD9 has done is when you do like a, what do you call it, the PTCA to open up or to add stents. If you do it on one vessel, or you do it on 2 vessels or 3 vessels, the costs are different. And so ICD9 has the main procedure, and then there's the supplementary procedure code that you add. So you have 2 codes. One indicates the number of vessels, and one indicates the actual main procedure. So those will be important for the DRG. The same with stents, you put in 1 stent or 2 stents. They may be in the same vessel, you have 2 stents. So it's not 2 vessels, so they make a distinction also on the number of stents inserted. So these are just things that as we're going through the ICD9, as you're comparing, as you're looking at the map, you can see that in ICD9 these are important distinctions, and I'm not sure in RBS if they do make the same distinctions, but they do affect the DRG grouping. Okay, so now let me just introduce a bit the hierarchical structure of the ICD9-CM. So ICD9-CM has 18 chapters. They're numbered from 0 to 16, and there's an extra chapter 3A. There are 100 2-digit categories from 0 to 99. So these are smaller subcategories within the larger body systems, but they're still pretty high level. They're not used in patient records, but they help you to understand the overall structure because the first 2 digits of the codes will be based on these digits. Then there are 3-digit subcategories, almost 900, 3-digit subcategories. In some cases, there's no further subdivision. So the 3-digit code is valid. But in the case where a 3-digit code is further subdivided into 4 digits, the 3-digit code is invalid. So you should use the 4-digit code. So I found this in the current mapping. There are some cases where maybe it's 40.4, but it should be 40.40 or 0 or 1. If it's just 40.4, it's an invalid code because there is subdivision. So anytime there is a 4-digit subdivision, the 3-digit is invalid. So that's just a really important thing to know for the ICD9 use in clinical coding and especially for DRG. There is an exception in the DRG. Some of the codes were updated from just 3-digit. They subdivided into 4 digits from 2010 until now. So this recent revision, the way that the Thai DRG dealt with the revision was they allowed simultaneously they could accept 3-digit or they could accept the 4 digits under the 3-digit. But it's for only a very limited number of codes. So if you do find this as we go through examples, some case where the 3-digit is used and there's already 4-digit, it's these new updates. And that's the only case that 3-digit is still valid when 4-digit exists. So this is really important. There are 3,883 valid ICD9 codes, including the 3 and 4-digit codes. And so that includes some of the 892 in the case that's not subdivided. So RBS, how many RBS codes are there? It's also less than 4,000. Okay, so let me just go through the structure of ICD9. And when Dr. Chairaj explains to you about the group, you'll notice some important similarities and also some differences with RBS. So I'm going to go through the bold ones first. So the first code system is the nervous system. So all the codes in the nervous system start with 0, 1. And then the endocrine system comes next, and then the eye. Skip 3A for now and go to the ear, nose, mouth, and pharynx. And you'll notice this is a little bit different from RBS. Because RBS, they put the mouth, lips,
as part of digestive system, and the nose is part of respiratory system. The ICD9 system, that was separated into specialty like the ENT, ears, nose, throat, but also dental is part of the mouth section. So it's an important distinction that's very different in the structure between RBS and ICD9. So respiratory system, cardiovascular system, humic and lymphatic system, I think these are generally similar except the differences about the lips, mouth, and nose, which are separated. The digestive, urinary system, male genital organs, I think you also separate those or combined in RBS, but they're closely associated. ICD9 separates between the female genital organs and obstetrics, but I think in RBS that they're more combined. And then operations on the musculoskeletal system. And then the integumentary system includes also breast. So the breast codes are also included with the skin dermatology codes in that breast category. So you can see in the chapters, but the actual codes, the first two digits of the codes are in the parentheses on the right side. So all the codes starting with 01 to 05 will be in nervous system. But they have this sort of code for the overall structure. It's a little bit different. So when you're coding, you're going to be using these kind of codes to distinguish the different categories. So I also, in the RBS, I went through and found what is the range for the nervous system codes, goes from which number to which number. But it doesn't seem to have the same kind of structure. But generally, like digestive system will be within the same range of the 10,000. So let me go now to explain the category 00 and the 3. So after they created ICD9, hospitals kept innovating and doctors created new procedures. So they had new procedure that didn't exist before, intravascular ultrasound. So when they first made the system, it didn't exist. So then they found that they didn't have any place to put it in the right body system. So they put it in category 00 or 3A, robotic surgery, computer-assisted surgeries. So that was one reason that you have these extra. And then, so when you're going through and you're looking at cardiovascular disease, you need to be very careful, not only look at the codes from 35 to 39, but also search in 00 and 3A to see maybe there's also a procedure that's related to that body system. So this is really important when you're looking at the mapping, because if you map only based on this one, you may end up missing important procedures. So all the laparoscopic hernia repairs, I think those are all part of 00, because the laparoscopic hernia repair is something relatively new, and so it wasn't in the digestive tract, it was put into 00. So you just, when you're going through any disease, just skim through the categories in the 00 and 3A to make sure you're not missing important ones. So that's those two. And the last category is 16. So this is ranging from 87 to 99. So the codes starting with 87 to 99. These are non-operating room procedures. So mostly they're non-invasive. Could be radiotherapy, chemotherapy, radiology, psychological examination or evaluations. So these are procedures that are not generally part of DRG, because DRG is really focused on operating room procedures. But sometimes there are procedures within this last category that are used in the DRG. And just some examples, for cancer cases, there's a subcategory in the DRG for diagnostic procedures. So this can include biopsy, which is included up here, but it can also include radioisotope scans. So radioisotope scan, like PET scan, would be something in the 87 or 88, or nuclear medicine, which is in this group. So there are a few, I think about maybe 100 of the codes in this last chapter are used in the DRG, but they're not operating room procedure. They tend to be supplementary codes that do influence the DRG to which the case is assigned. And Dr. Tyrus can talk about that in more detail later. But just so you get the overall structure, whenever you're
looking at an RBS code and you're trying to see which one does it fit into, the first thing you're going to do is which chapter does it go into. So this is the first crucial part. So now let's get the two-digit codes. So the two-digit codes, for example, nervous system goes from 01 to 05. So they divided them is they have skull, brain, and cerebral energies. But they have two categories. One is all surgeries that are considered incisions or excisions. And then all the other ones, all the other kind of procedures for that body part. So it's a combination of the procedure type and the disease or the body part to further subdivide. Then all of the spinal cord operations are in 03. So if you find any RBS code related to the spine, you know, okay, we go here, and we find what is the equivalent code. Cranial and peripheral nerves, so there will be further subsection on cranial nerves and peripheral nerves. And the last one is on sympathetic nerves or the ganglia. So you can see the subdivision is still very broad categories of procedure, but it helps you. So you know it's a nervous system, now you know within nervous it's the spine. Then you can go further. But that's the crucial skill that you need to learn to check the map or even in the future to guide hospitals and how to coping. The musculoskeletal system is also subdivided. All of them will be subdivided. I just gave you some examples here. You can, we're going to go through all of the chapters so you'll get to see them as we work together. Musculoskeletal system, so operations on facial, bones, and joints. So this is important because as I was going through the map, I found that there was something, it was a procedure on the jaw, but it was categorized as category 77 or 78. So obviously if it's a facial bone, it goes in 76. So any facial bones, any skull bones, that's not the craniotomy, then it's going to be in this category. So any of the plastic surgery to fix the jaw, make it look very handsome, going to be in here. But there are some exceptions. For example, nose bones tend to be section on nose rather than section on bones, because a lot of that is cartilage put in the section. These are all things that when you use the coding system, you start to learn different categories. Also, this is something different in the structure between RBS. So RBS seems to structure first like the body parts, and then within the body part they have all the bones and muscle tendon all together. Whereas in the ICD9 they put the muscles and tendon, the soft part is a separate category. So something you should be aware when looking at it is that if you're talking about any of the soft parts, the soft tissues, then it will be in the 82 to 84. And also joints. They separate joints from the bones. So when you're talking about the elbow, in the RBS, it's put together with the arm. But in the ICD, all the joints are going to be put in this separate two categories. So these are important things that you should notice so that when you do check, when you're reviewing and validating, you notice that, oh, I know there's a one for joint, why is it put with the bones? So you can check. Okay, now going into the 3 and 4 digit codes. So I'm trying to choose different chapters so you can see different sections. So this is the eye. The eye is very complicated. It's a very small organ, but it has many, many different detailed parts. And the operations on the eyelids, the lacrimal system, conjunctiva, the cornea. So all of these different parts of the eye, they will have the procedures related to those parts. And the procedures are very different for these different parts of the eye. Another thing that I wanted to start introducing to you is in the ICD9 system, like the RDS, you have some information below the name of the procedure. So this is additional guiding information, so you know to include, for example, if it's the eyelid, but what if it's about here, this part of it is the eyebrow. So it's like, oh, it includes also surgery on the eyebrow. So you know that because that information is in the coding system. And in this one, item 12, it says, this operation, the iris, ciliary, body, sclera, and anterior chamber, but don't include cornea, because cornea has a separate range in the category 11. So it helps you to know, okay, If it's cornea, don't put it here, put it in another section. And here, operation on the orbit, the bone around the eye and the eyeball. But if it's a reduction of the fracture of the orbit, it goes to musculoskeletal. And these 76 is facial bones, right? So this is the idea to avoid misleading, but also as you're checking code from RBS, you can see this information is really useful to help you check whether it's in the right group and it's the right procedure. So I kept it the same eye procedure to show you the 3-digit codes. So we looked at the 2 digits, but now we're looking at one of those, the 13.0 to 13.9. And you can see the excluding, but also you have some that's in code also. That means that you should put 2 codes. So if you use that code, then you also need to code an additional code for inserting the lens for cataract surgery. And then this one, so they give you actually the code that you need to add. So it really helps you to know that when you use that one, you're going to have to also add 13.71 to know the right code. And this is just all the surgeries on the lens. So have remove foreign body, but don't include removing the lens, right? So it tells you don't exclude that one, or don't include that one when you use 13.0, because that one is in the later one. There's another code to use for that. But you can see these different extracapsular and intercapsular extraction of the lens, and then there's other cataract extraction. And which one of these is phaco? Do you know which one is phaco? Fragmentation. Yeah, before. Okay, so now you have 3 digits. Now let's go to these are 4. Yeah. So now a 4-digit. So this is all of the 4-digit codes related to the lens. Okay, so we're digging down to the highest level of granularity. So one thing you notice, there are some blue letters. So I tried to indicate, for example, removal of foreign body from the lens. You can do that with a magnet. You can do it without a magnet. But if they don't write anything in the patient record and you don't know which method they use not a well-specified method. Okay, so this is a group of 3. Other. So other is also used. That means that it's not listed above, then put in this category. So the other is important category. You notice that there are 3 codes with just 3 digits. So there's 13.2, 13.3, and 13.8. So these are codes where there's no further subdivision. So in the patient record, you can use these 3-digit codes. For all the others, you cannot use the 3-digit, you must use the 4 code. So this is just, I chose one, but there are 99 different 3 digits and 3,400 codes, so it's a lot. Okay, I mentioned already about this. So just to remind you about some of the terms. So sometimes you see NOS, it just means not otherwise specified. So it's not specified in detail, so then you can use that category. So if they didn't specify approach, but all the other ones specify approach, then you can use NOS. Not specified, it means that there may be other codes that are similar that if it's categorized in those groups, you use those groups. But if it's not classified in any of those groups, then you can use this last category. It's specified. It's not specified. Not specified means there's no information to exactly what it does. But not else specified means it was not classified anywhere else. But we know what it is. Other is the catch to catch all the remaining ones that are not in the specific categories. The code also guides you when you have to use more than one code, what the other code should be. This is really important for the DRG on the stent, for example, that you should code also the number of stents inserted. Excluding, so when you see excluding, it means that so that category doesn't include the word after the excluded. If it's one in the excluded category, look for another code to use. Don't use that code. And then the inclusion terms are just additional terms that may be synonyms, they may be similar procedure that fit into the same category. And the term inclusion is not usually written, it's just listed. So when it's just listed, it means these are alternative terms or alternative types that fit in the same category. So those help to guide you if you're not exactly sure the verbal approach or not the verbal approach, then you can see that, oh, verbal approach, so that it fits in this category. Those are, they're not additional procedures, just these are other procedures that fit into the same category. So I think there may be some misunderstanding with the RBS that it means and also this procedure, but no, it's just another term or another type that fits in the same category in ICD9. Okay, next. This is something more for when you're using the information. IT people will be very sensitive to this. The code structure is a text format, it's not numeric. So when you're using text, you need to be careful that you're using text because 0.13 is not the same as 0.13 as 13.0 and 13.00 are different. So 13.0 is not the same as 13.00 because 13.0 is 3-digit and you can have 4-digit 13.00. So it's really important whether the 0 in the front or the 0 in the end, don't drop it. And so it's important when you're using the text codes, if you put an apostrophe before the code, then it will fix it as a text. So I found a lot in the mapping that any of the codes are listed without the apostrophe before or not as text format. And so sometimes the end zeros got dropped and then it's not a valid code. So it's really important to remember this when you're working with the codes, when you're revising the code mapping, when you're mapping with the DRG, make sure that you're using the codes as a text, not as a number. The other is that in the Thai DRG, they don't use the decimal. We don't need the decimal. We can get rid of the decimal. So the number I put in the square brackets is what the equivalent would be in the Thai DRG. So you can just drop the decimal when you're working with the data. But make sure you keep all the zeros. If it's 013 or 0130, it's important. Okay, so I'm not sure, has everybody received the files? Yes. Already emailed. Pardon? Already emailed to them. Okay, so what I wanted to do to do what time is it? 10. So if I go to about 10:15 or 10:20, it should be 10. Yeah, then you have enough time. I want to make sure because the part about the ICD9 to DRG is really important, and Dr. Tyraj will show you interactively on the Blueprint how it works. But I wanted you to start looking at the ICD9 coding system. So there's a reference file for the ICD9 classification. And then there's also a separate one that has the full RBS plus the RBS structure. And I wanted you to start to explore it. So we'll go through some of the ones that we'll work on this afternoon so we can get a head start. And this will also be important when we work with the clinical societies. We need to be able to explain to them how is the structure of RBS compared to the structure of the ICD9. Because they know RBS, but they don't know ICD9. So we need to explain to them how is the structure of ICD9. So here we have the nervous system, ICD9. You have categories 1 to 5. You have some additional information that they include that you would generally use adhesion barrier substance when you're doing these kinds of spinal cord surgeries. So they would ask that you also code that code. And I'm not sure in RBS if they have this approach to coding. And then to exclude if it's a paracervical uterine denervation, so that's related to obstetric or the gynecology. So then it's not included in this category for nervous system. So if you can open up your file for ICD9 that you have now on your computer, but now everybody's eating. Maybe work together as Where's the two? So also, if you can open up the section on the nervous system from the RBS.
Sarah, the file of RBS and the ICD9?
Yeah.
ICD9 and RBS files.
So I took this full RBS that I received from Union Health and I create the structure. So the structure you can see. So if you look at the RBS, on the furthest left column, if you move down, you can find the nervous system. So in the RBS version that I have, I didn't see a lot of subdivisions, so it's not very well structured. But there may be a better structure. But it seemed that everything was just list of procedures. So remember in the ICD9 that we had the two sets of procedures related to the skull, the meninges, and the brain. And then we went to a group on the spine. And then we had some procedures related to the peripheral and cranial nerves. So in the RBS system, I found one category for skull, meninges, and the brain. And then many subcategories. And then you know that the spine and spinal cord, and then extracranial nerves. So there were sort of three big categories. Similar ICD because they also are spine.
So that means that when we're looking for spinal cord issues, we can look in the same subgroup within RBS and the same subgroup in ICD9. So that makes it easier for us to find the right code. Right, so within spine there is a limited number of codes, so we can easily check. We can ask the experts the clinical experts to look at the names. Do they match? If they don't match, we can then easily search to find an alternative. So I think this what's different is underneath the structure underneath is different between the two. So there are just three main subcategories in RBS. But in the ICD9, you have, so from 01, code starts with 01, you start, and then you go down to 05. So all of that set of codes. So I was looking at the two systems, and I was looking for carpal tunnel. So carpal tunnel is a very common procedure. I think you have a package for carpal tunnel, or do you have outpatient ambulatory surgery for carpal tunnel? But it's a very common kind of a procedure. So is that a nervous system procedure? It's about the nerve in the carpal tunnel. In RBS, is it based on the nerve? Maybe you can search the RBS, find the tunnel. So the term used often is the carpal tunnel release or decompression. You found it?
What name of the procedure? Yeah. We just received carpal tunnel, neuroplasty, and all kinds of procedure.
So it's about the nurse.
Yeah.
Neuroplasty and neuroplasty. Okay, is there another one, that's about the carpal tunnel that's in the, related to the tendon? Sometimes even this classification system is difficult to know. Is the procedure really a procedure on the nerve? Or is the procedure actually cutting a tendon, which is musculoskeletal, cutting the tendon to open up the space for nerve? So is carpal tunnel, is it neurological or is it a musculoskeletal? So how do the doctors in Vietnam, and this is something we can ask them when we meet them on Wednesday, how do they quote carpal tunnel? Because I see in RBS there's also a procedure to open up the tunnel by cutting the tendon. So in the DRG, carpal tunnel release is its own DRG and it's part of the neurology nervous system. But it's possible that a surgery that has two different ways to deal with the same disease, they exist. So they may have two different procedures. One is musculoskeletal procedure, one is neuropathic procedure to achieve the same thing. So I think sometimes we need to look carefully and we need to be able to search easily within the RBS to find. So we sometimes have to know alternative terms. So carpal tunnel, is it a decompression? Is it a release? Like what is the procedure being used? So this is why the clinicians are really important to help us to understand and to find really another term that's has the same meaning. But hopefully they also know very clearly what they're using in the RBS code. So have they had training and are there national standards on procedure code for RBS? Did Phil not do any training for hospitals to know how to code the RBS? Is there any document that explains how to decide which code to use? There's a list? The description of the procedure.
Which will be the basis for the surgeon
to code. Okay. So what about in the case where they take a craniotomy is the procedure, but it's not for releasing of pressure from a hematoma, but they do craniotomy so they can do a biopsy. So in the RBS instruction, does it say that they should code both biopsy and craniotomy? So if you look on the RBS code, you have the biopsy, but I think it's a vertical approach, right?
But I think there is description in the RBS whether it's for biopsy or for treatment.
So my question is, if they do a biopsy, but they have to do craniotomy to get to the place to do biopsy, do they consider it as two procedures or one procedure?
Well, for field health purposes, we will only pay one procedure.
One procedure. And so between craniotomy and the biopsy, the higher price one. Okay. So that's consistent with the DRG. So in the RBS system, if you do biopsy requiring craniotomy is more expensive, so then the case will be categorized as craniotomy.
Yes, unless because in the RBS, I think there is I don't know if it's craniotomy, but there's a craniotomy for biopsy, and that might be have a higher.
Okay. Okay, so I think when we talk with the definitions about the mapping between the RBS and ICD9. In many cases, we're quoting from one to many, but we need to be very clear if that one is a really multiple procedure or if it's just a single procedure. So there need to be clinical coding guidelines to make sure that people are coding correctly one code and which code to code, because this will also affect on that. So I think this is something that we, as you move along towards the journey to DRG, this will be something we'll have to talk about, is also the coding guidelines, to make sure that they're not gaming the system and they're not over-coding too many procedures. But in fact, Dr. Charas was talking a little bit about how the DRG actually has a way to get around this issue, because they choose one priority procedure to be the one used to assign a DRG. I think we'll talk about that later. Let's move to the musculoskeletal system of head and neck. So this is one that we wanted to work on in one group. We want to have your nervous system, head and neck, musculoskeletal, eyes, and ears, nose, throat, and mouth. So we're going to have one group that's going to work on these 4 different categories, or multiple categories. So this one, I just wanted to remind you, when we talk about bones, the distinction about the face and neck. So bones of the face and neck. But here again, you can see that if it's bones related to the sinuses, so sinus, this area, it's in the bones, the holes in the bones, right? But those are categorized into the nose section, nose and sinuses. So it's not part of the facial bone because you're talking about the hole rather than the bone. But anything related to sinuses will go in there. Nasal bones, again, is part of the facial bone, obviously, but it's treated in the section of the nose. And bone, craniotomy and procedures on the skull are categorized in the nervous system in the ICD9. So the category 6 is all the other bones like the bone or the cheekbones, other bones on the face. So I think the scope of what's covered in the different books is very different between RES. So the general broad category is okay. Yeah.
How can we map the laterality of the facial bones? Laterality, left and right, since in the RBS and the ICD10, they already defined the laterality. However, it seems there is a question on the laterality on the ICD9. So my question is, how can we map if it's concerned the left and right part of the face?
Yeah. So this is something I'll let Dr. Charosh talk about a bit when we talk about the DRG. So there are different purposes. So for clinical purposes, so ICD9 does not indicate left or right. RBS also indicate left or right. So if you're doing left eye, it doesn't indicate. And so you can put, I don't know how the system is, you take 2 quotes, same quote.
Or if you have a different way of coding when you have 2 eyes done at the same time. Do cataract surgery on 2 eyes. How is that coded in the field health system?
That's a different treatment. That's a different procedure.
It's considered as 2 separate independent treatments, even though it's on the same
face.
episode.
Yeah.
The same episode of care. It's considered as double.
Okay. So in the Thai DRG, they have a special way to code the procedures that has an additional element for items that have multiple times or duality, like it's done on two sides of the face. But I think Dr. Charosh will talk about how that looks in the ICD9 to DRG. Obviously, I mean, the ICD9 does not include
I believe
that side by side.
We'll hear from the gentleman.
It's a very good question, relevant, because obviously doing 2 eyes will cost more than doing 1, but not double, right? So it doesn't cost double to do 1. Okay, so just go through the eyes. So we already talked a little bit about the eyes, so you know generally the structure. But we're going to, so this afternoon we're going to go through these in more detail, and we're going to look at the map and try to see where there are problems between the RBS and the ICD9 structures. But I think for eye, it's not too bad because it's the divisions of the eye parts are very similar, so it's not so difficult. And then the ears, also the RBS and the ICD9 have similar structure, looking at external, middle, and inner ear. But one thing is different in the RBS. Some of the nerves in the ear, there are some procedure on nerves in the ear that are included in the section on ears in RBS, but it's part of the nervous system in the ICD9. So there are just some small differences that you can easily search using the filters in the Excel. So everybody here, I'm sure, is quite familiar using filters to filter data, to filter tables in Excel. And then VLOOKUP also. So if you, for example, you have the Thai DRG, ICD9 code used in Thai DRG, and you want to map to see is that Thai DRG use this ICD9 code, then you can use VLOOKUP to check if the ICD9 code is actually used. So people here are familiar with the VLOOKUP command? Or not?
With the what?
VLOOKUP. I'm sure you, every year, very good at that. But, so that's something when we're working together, we're going to be preparing the documents for the workshop on Wednesday. So we'll need to provide as much additional information for the clinicians to know, to have some hints that maybe the mapping is correct or incorrect, or maybe they want to revise the mapping because it's not used in DRG, for example. Then maybe say, oh, but it's a very serious operating room procedure. Why is it not in DRG? Maybe it was mapped wrong. So there are things like that that we need to be able to compare coding lists. And so we will have to be important. So I think I'm going to stop here. There's just notes now. And so again, this one is very different between RBS because the digestive tract includes the mouth and throat, and the nose is part of respiratory tract. But in the ICD9, they count larynx as part of respiratory, and pharynx is separate category. And then the next, so this afternoon we're going to work on these 4 general categories, and then we're going to spend half the hour on those, and then half the afternoon we're going to go into respiratory, cardiovascular, the hemic and the lymphatic system, and radiology. So we consider that those are somewhat similar related thoracic surgeries that it makes sense for us to bring clinicians together to work on related surgery types. But we'll go through that in the afternoon. But let me pass to Dr. Charles.
Ano po percentage? Those attending on virtual platform, any questions from the attendees? Online. We have some questions online. So, how about fractures of the nasal bone?
Fracture of the nasal bone. I'll have to check in the structure. If you look in the ICD9 structure, it seems to be in the nose section. I think
think you already answered it.
Yeah.
Yes. Opo, kanina. Basta
Pwede ba ito touchscreen?
Okay?
Thank you. Dr. Jones, sorry, I just have a question. On transplantation, because it involves different organs and different issues, so where would you, when it comes to ICD9, what issues that post-transplantation? Question here from Sergeant.
Okay. Just for a clarification and curiosity, I heard that there are 19 times many procedures in the ICD-10 as compared to ICD-9. So how do we treat those not available in from ICD-10 to ICD-9? Thank you.
The ICD-10 PCS is a new system used in the US. And so basically the ICD-9 is a grouping of the ICD-10 PCS. ICD-10 PCS distinguishes further. So for example, laterality, is it the left side or right side? Is it this part of the bone, or this part of the bone, or this part of the bone? Is it using synthetic mesh? Or is it using which material is used in the implant? So the specific materials will be listed as separate category of code. So the level of complexity and detail is much greater. And how system that's needed for DRG is not needed, this level of complexity. But to do that, it really requires that you have all the code is supported and assisted using the computerized analysis program. But it's just that you're getting down to much more detailed level of what materials were used, and which side was done, and which approach was used, and which part of the bone was treated.
So, follow-up question. So, if there is no equivalent code in the ICD-9 from ICD-10, because there are many codes in the ICD-10 as compared to ICD-9. So how do we map these procedures which are not available within the ICD-9 but available in the ICD-10?
So the ICD-10 PCS is a procedure coding system of the ICD-10 PCS. There is a map available by CMS how to map between ICD-9 and ICD-10 PCS. In the ICD-10 PCS, there are very few new codes that do not have an equivalent, but it's very limited, and generally there are the latest innovation that's still not available in Asia. So it's not something we should worry about now, but in the future, when the IT system becomes stronger, and you can move to more granular coding system if you need it, then we can consider adopting.
So we just do it once.
So we can give it a few years.
Thank you.
Thank you. The participants may have a 10-minute for me continuing with Dr. Susan for 10 minutes.
Question po from the floor, from the virtual floor.
Question from the virtual floor.
Yes po, this is Auxilios from the Philippine Obstetrical and Gynecological Society. Our invitation is for a virtual meeting this morning from 9 to 11 in the morning, and a face-to-face on Wednesday, 9 to 4 p.m. But we now see the importance of this, and it was presented beautifully by our speaker. Is it possible that we may be able to to join the discussion, especially tomorrow. The discussion will be on obstetrical and gynecological procedures. Can we attend that as well? Pwede po?
Doctora, we are on a break. We are currently on a break. We will address your question in a while.
Okay. Yes.
We'll get back to you after the break.
Yes, sir. May I also ask if it's possible we join you face to face? It's quite tedious and cumbersome for us dito on the virtual floor.
Yes, on Wednesday.
On Wednesday, but what about tomorrow? Because the gynae procedures and the OB procedures, we would want to take a closer look and learn from the proceedings. Would that be possible?
You may join us on Wednesday. Technically, the session day for the specialty societies on Wednesday, September 21.
Oh. Okay po, sir. Thank you. Thank you.
Thank you, Mara.
Thank you po.
Extra table.
From ACR, the latest ACR. All case rates? Yeah, all case rate. All case rate for inpatient or to analyze. I think so, because after Wednesday,
Pangit ng budget, nakakabor.
and
Wala tayong nagpipyan.
we make a modification.
Yung Joyce, hindi ko ba dito na po? Ito pa rin po. Ayan na, nag-ano na, na-share ko na. Tingnan mo daw. Tingnan mo daw, nag-share na ako. Ito na sa akin, yan pa rin. Ayan po.
Yung sa Direts.
Ito lang. Bukas may konting OB, pero sa anong group 5 bata tayo sa Wednesday? Wednesday na lang. Wednesday po. Yes, ma'am. Ma'am, Edsa Shangitan. Yes po. Yun nga eh. Ako yung voice. Tingnan na ako yung ICD9.
Diba natin, pag tinignan ninyo yung procedures natin, may mga ano na doon, hindi na ginagawa like Pereira. Mapa nila, hindi na yung ginagawa. So, ang goal din natin
So next speaker will give a talk on procedure data in ideology. Dr. Sarah Shulfanico is for pre-medical education and obtained his Doctor of Medicine at the Mahigaon University in Thailand. He is trained in internal medicine with certificate of proficiency from the Thai Medical Council. At present, he is a consultant at the Health Information Standards and Processing Administration under the Health Science Research Institute, an active member of the IERG Development Team, and his professional background includes the following: he is a doctor at the Department of Medicine, Faculty of Medicine, University, practicing attorney at the National Children's Hospital in Bangkok, Thailand, medical director of the National Children's Hospital in Bangkok, and assistant director of Central Office for Healthcare Information under the Health Systems Research CCC. Ladies and gentlemen, Dr. Sarah Shulfanico.
I will talk about the processing but before posing the procedure, I want to talk about the protein. The protein IDNT protein has a patient data, and here you can see for the group here, the simple data. These are the input data for Thai diagnosis. This is the clinical diagnosis, secondary diagnosis, procedure. And also the data about age, which we divided into two parts: the age India and age the linear from the year is the day. Then another the sex, where you will stay in each other. This is for the detail of the principal diagnosis. This is the main disease or condition. This is the cause of care for that hospitalization. Only one code for the principal diagnosis. We use ICD9 for the diagnosis. And the other diagnosis we call secondary diagnosis. This is the disease and the conditions which are also treated at that episode of care. The entirety can be known or up to 12 secondary diagnosis in one episode of care. And so we use ICD-10 for. Now we go to the procedure point. This is the operation or intervention which are done in that episode of care. There can be low or up to 20 procedure code. In Thai DRG, we use the ICD9 and procedure code for the procedure code. Other data for the age and the age they calculate on admission date and we calculate the age into two parts. The part in the full year and the part not in full year. This is the example. And for the previous day, we calculate from the date and time of the child and the date and time of admission. And we if the for the length of stay, we calculate in the number of days. So we from the date and time of each child and at least if 24 hours we come at 1 day. So 2 days must be 48 hours. But in some cases they're not in full day. So if not in full day, if it is less than 6 hours or less, it's not add. If it is more than 6 hours, it's add 1 more day for the remainder. And in Thai, some cases not very difficult. Some patients stay in the hospital, and during the stay, they go back home and come back again in the same condition. The number of days they go home before leave there. So if they usually leave there is 0 because the patient stay in the hospital all the time. But if they are there, we will subtract the leave day from the length of stay after calculate. Okay. For the discharge time in Thai health system, we have the code for the discharge time. 1, we get approval from the doctor, and 2 is again advice, 3 escape. Okay, now to 9 days with or without autopsy. And from that data, to get the DRG, we have the steps. We do in 3 steps. The step 1 is to find the MDC. The next step is, after you get the MDC, you find the DC. Okay. And after we get DC, we calculate for the DRT. I will show you us. Okay, now. The MDC is here. We have MDC 00, that means pre-MDC, that's for the high cost, such as transplantation or liver transplantation. Okay. And then MDC 1 to MDC 25. And we also have 26, MDC 26 for the unrelated OR procedure. This is the algorithm for MDC determination in DRT. From patient data, we do the demographic and clinical, it means the checking, data checking process. And if the data is okay, then we try to determine if it's in pre-MDC or not. And for the pre-MDC, check for some particular diagnosis and procedure code. If there are the diagnosis and procedure code in the pre-MDC, it go to the pre-MDC DMT. Okay. And if not in the pre-MDC, it calculate for the special MDC. It is MDC 24, 25, and 15. It uses more data, such as principal diagnosis, secondary diagnosis, procedure, and age. And if not in this MDC, then we use principal diagnosis to determine the MDC from MDC 1 to 23. So you can see we must have we use the principal diagnosis for most cases to determine the MDC. This is the diagram in PHIC version 5 here of patient data. This is the checking data checking. In the checking process, there are errors of data. If you give the result in the number, these three numbers, it means that it is unprovable. So that is cannot prove. Okay. If this is the next step is checking for the length of stay. If the length of stay is more than 6 hours, it goes to here. But it's not more than 6 hours, it go to MDC 28. But only for the short stay, staying 6 hours or less in cardiac version 5. Okay. And here is the pre-MDC part. This is the pre-MDC, liver transplantation, lung transplantation, bone marrow transplantation, and also the three DRG. This is the high cost DRG. Okay. And if not in the pre-MDC, then it go to the MDC 24. This is called multiple significant trauma. And after, if not MDC 24, it go to MDC 25. And if not in MDC 25, it check for the age. If the age is less than 28 days, it go to MDC 15. After that, it uses the principal diagnosis to calculate for MDC 1 to 23. Okay. Okay.
In this illustration, given that in the first submission there are uncertainties as to the primary diagnosis, does it mean that the DRG are pseudocodes?
Yes. Yes.
Yeah, that's pseudocode, I think.
Yes, that's correct. It's invalid principal diagnosis. No principal diagnosis. So this is the step one. You have to determine what MDC the patient is, the data is. After you know the MDC, we look for the DC. To determine the DC, we have the algorithm for each MDC. So for every MDC, we have the algorithm, and that is in the book, in volume 2 of the TIDRG book. Okay. What is DC? DC is a proof that patient is interacting concept such as craniotomy. The craniotomy for trauma patient and craniotomy for non-trauma. Non-trauma such as the CVA, several different from other cause. Okay, appendectomy, gastroenteritis for patient age more than 9 years. There are many, about 600 diseases in cardiology. And for in each MDC, the typical in the MDC algorithm, MDC logic, it starts with looking for the procedure. We call MDC procedure. The MDC procedure is the procedure that related to that MDC, such as if for the nervous system, that is MDC 1. It's about the nervous system. So the MDC procedure is the procedure that related to the nervous system. Okay. And in the procedure that related to the nervous system, we still have subgroup into what we call PEC. Okay, it's a group such as the craniotomy, the code of operation in the head and the brain, and also the operation for the spinal cord, and also operation for the peripheral nerve or something like that. So from MDC procedure, we subdivide into the smaller group. We call PDC, and from PDC to DC, very simple. For PDC1 to DC1, but in some case more complex. I'll show you later. And if not in the MDC procedure, the procedure in that case is not in the MDC, in for that MDC. We look for whether there are OR procedure or not. If there are OR procedure, we go to the unrelated OR procedure. It means that the procedure is not related to the disease, the principal diagnosis. And if there is no OR procedure, we use the principal diagnosis to subdivide into DC also. But for the diagnosis code, we also have PDC. Okay? The PDC is the subgroup such as the disease of the nervous system, disease of the brain. It may be subgroup more such as the operation, CVA, or infection in the brain. And disease of the spinal cord, maybe traumatic or non-traumatic. Okay. And that's the typical DC, typical algorithm for the DC determination in most MDC, most not all. Okay. Here this is an example of this DC determination in MDC1. MDC1 is the disease of the nervous system. You can see first we look for the tracheotomy. And with the tracheotomy, we look for length of stay. If the length of stay is not more than less than 21 days, it was 3 weeks. It go back. It less than it go back earlier. If it more, it 21 days or more. It look for the continuous mechanical ventilation. So the patient on the ventilator for more than 4 days or not. If it have in the ventilator for more than 4 days, go to DDC. If not, go to DDC. So okay, after that, we look for the MDC procedure, and we look for the multiple craniotomy. Multiple craniotomy means that in that episode of care, they have to do the craniotomy more than one time. Such as patient with cerebral hemorrhage. Sometime after the first craniotomy to evacuate the bleeding, the hematoma, then a few seconds. The patient person might have some problem that they have to do the craniotomy. This is the multiple craniotomy. And we look for the principal diagnosis is trauma or not. If trauma is equal to this, easy, and if not to this, easy. Also, if not multiple diagnosis, we look for plasma disease, intercraniovascular procedure, spinal procedure. This is also the hierarchy. The top is the top hierarchy. It means that if the patient have any more procedure, we need to be what kind of procedure the patient has if it has multiple craniotomy and here spinal procedure, we go to this procedure, only this one, not this one. Okay. And after we look for the MDC procedure, if no the MDC procedure, we look for OR procedure, and if there are OR procedure, we decide to MDC, UDC here, according to the logic for this and after that, we look for many subgroups using the principal and assign the DC. Okay, yeah. And you can see that in some branch here, some DC is simple. We have DC and have DC here, but for the neuroplastic, we also look for other data to classify into the subgroup. About 6 here and here. Okay. It's also in MDC1 because there are a lot of subgroup of the diagnosis. And that is to get the disease. Then the third step is the DRG determination. Typically, we look at CC and calculate for PCCL. And with the PCCL, we get the DRG from DC and PCCL, we get DRG. Okay. I will not go much detail for the DRG determination because it's about into the secondary diagnosis. But today we concern with the procedure data. I just put it here to make it complete. Okay. And here is after you get the what we call PCCL. DRG is the DC plus PCCL, such that if you have DC 0101 and PCL of 0, here the DRG is just the number. DC plus DRG and PCL. And this is an example of DRG. Because of the data, some DRG can help find. Somebody can have 5 DRG, but if they have only one DRG, not every DC have 5 DRG. Okay. It depends on patient data. If there are very few cases, you don't subdivide to DRG.
This is type.
So some. Now in the example, it's a man, age 22, was admitted to a hospital because of abdominal pain and other symptoms. Appendicitis was diagnosed. Appendectomy was done. His symptoms improved after surgery. And he was discharged on the 3rd hospital day with the admission of the doctor. This is the patient data. We summarize into the grouping data. Like this, 22, sex 1 in male. Okay. Length of stay is 3 days. We calculate from the date and time, admit and discharge, and we get 3 days. Okay. And discharge time 1 for group 1. The principal diagnosis for appendicitis, the ICD-10 code is KT5. No secondary diagnosis. The procedure is the appendectomy. This is the ICD-10. With this data, the Google will give you the data. The DRG is here 0.070. Appendectomy also relative weight here 0.6. Clearly discuss about procedure. So in this case, there is no procedure data. What happens? If no procedure data, the DRT will be here. The DRT is 0.0. The DRT that is under diagnosis. But under digestive system diagnosis, not confirmed, no issue. And the relative weight is here, only 0.56. Length of stay, this is the average length of stay. But the relative weight is okay. So this is the important of the procedure data. If you have no data, it means no operation. Even if the operation was done. So procedure code in Thai DMT. For DMT version 5. At that time we used the ICD9 CM 200. Procedure code. At that time the total number of coils is about 8 here. Nearly 4,000 coils. Only about 3,000 codes are used in Thai DRG. About 1,000 codes are used. Procedure code in Thai DRG. We put the detail for putting in appendix B is the procedure code, and there are lots of there are data, other data. This is a code. This is the what we call ORP or OR procedures. OR procedure means that the procedure should be done, or should be done in the OR operating room, or maybe not the operative room, but the procedure is a high cost, so that you have the cardiac care, you do the cardiac care, and you put the stent or something like that. It's a high cost, so it's we determine that we define it as an OR procedure. Okay. So, and the OR procedure is what OR procedure is defined by the DRG system. Not reflect even in the insult in that hospital may do in OR or not in OR. It not matter because it is defined in the DRG system. For the ORP column, if the number is 0, it means the code is non-OR procedure. And if the number is 1 to 6, it means the code is OR procedure. If in the OR procedure, we divide it into 6 levels, 1 to 6. And this will be used in case of the procedure is not related to that MDC, that we call related to our procedure. Okay, and so this is the 2 big column. This code ORP, MDC, and this also. So here you can see the ORP of 0. So mean that this 4 codes is not OR procedure. And this 2 codes is procedure, OR procedure with the level of 5. And also this is level 4. Okay.
Clarification on the side, are we specific only to NBC 24? I believe in the ICD9 procedure, the main diagnostic categories are mostly procedural. The medical is the NBC 1 and I think somewhere down to 23 or 22. But 23 up, that's more of procedures, am I right?
Yeah.
And from here, why are we only specific to NBC 24?
You have to go back to the. I'm not sure we define. Okay, it is the detail, more detail, but the most detail is in the chapter of MDC 24. We define more. Here, this is just a synopsis. So you must have physical diagnosis of trauma and either significant trauma diagnosis or significant procedure from different body size category.
Yeah, my only clarification is because the presentation only shows use in NDC 24.
Yes.
So how about the other NDC that belongs to the procedures code? And another questions, we are keep on mentioning CC, which are the complications or comorbidities. I'm just curious why limit the secondary codes to just 12 and 20 for the procedures. Are there magic number for that?
Not so magic. Only for the secondary diagnosis. We just look at the number. That's most patients. We cover most patients. And also in the version 6, we calculate for the CR.
That's the most number.
The number is immediate. Okay. And also this column, MDC, DDC, or AX is of the sign is here. Okay. That is for this column, the number is PDC or AX. This procedure we use in which MDC. And look at this is the more simple. The code 4153 used in MDC 1, MDC 17, and MDC 21. And this code 4159 used in the MDC 21 as a PDC in the MDC position. And used in MDC 15 as a we call AX. AX is the auxiliary procedure. We can look at the AX in the book. Okay. And also the procedure in the procedure combination. Procedure combination. I mean that this code used in define yes, and it is a part of the combination code. Okay. And everything is very long. The long list about 3,000 code. Okay. For the procedure combination, this is a fixed combination of the code, and we leave the pseudo code here. Another code. So the code C 4445 is the combination of the code 3844 and 3845. So it's the restriction of abdominal aorta with retainment and resection thoracic vessel with retainment. So this is a big operation with the big vessel in our body. And two part abdominal aorta and thoracic vessel. And this book about the pacemaker, if you insert both the pacemaker body and the ring, is a combination code. This is an example of posterior combination in appendix C. Okay. This detail of the posterior. You can get more in the book, okay? And there are questions about if patient have more than one posterior code, how much it will be used in DRG. Actually, DRG calculate both every code that in the input, but the code will be used in the determination of the final, the DRG, how much it depends on which code it is. So in case with more than one posterior code, there are many times used. Okay. Most of the time, only one posterior will be used. And in this case, it divides to category. If the posterior is in the same MDC, such as in the gastrointestinal system, we have our resection and also anti-CORICs. This is about the gastrointestinal. The Google will see which code is in more hierarchy, in a more significant hierarchy. Okay. For bowel resection and anti-CORICs, bowel resection is in the more hierarchy. So it's select bowel resection. So this code is not used. But then here you can see, I'm not sure you can see that. Bowel resection will be here in this. I did it for you major, small, and large bowel position. The PDC is 6 PB. Okay. And for the NDCORS is here. So you can see this is the more hierarchy. So the patient will be able to eat this one. This is the example. The patient here. This is the diagnostic code. Here and here, and this is the procedure. So it just means this is the MDC procedure, and the Google will determine the PDC, and this code is defined in PDC 6PB. This code also is defined in 6PB. This is a small bowel resection, and this is anastomosis. And this is anti-CORICs. The anti-CORICs will define in PDC 6PC. And since the 6PD is higher hierarchy than 6PC, then 6PD is used and then the DC or C14. Like that. Okay, so the DRG is here. And if the procedure, there are many procedures, and the procedure in different disease, PURP, transurethral prostatectomy, and inguinal granulometry. It depends on the principal diagnosis. If the principal diagnosis is BPH, this might be seen for the anti-determination. If the principal diagnosis is hernia, it's go to herniolaphy. Because it relates to the principal diagnosis. Sometimes procedure will be used, more than one procedure will be used, such as here by MDC logic. If you have cholecystectomy, it go to one DRT. If you have cholecystectomy, we cross is common duct exploration. Post common duct exploration, it go to other DRT. That the DRT rate is more than cholecystectomy. And also in MDC 74, if you have craniotomy, you have one DRT, you get one DRT. And if you have craniotomy and ORIF femur, with different size, craniotomy head, ORIF femur in the thigh. Okay, it goes to different DRTs. These DRTs, the DRT made it more than this. Another case by procedure combination. Procedure combination defined in valve replacement and multiple valve replacement go to different DRTs. And also pacemaker insertion alone and pacemaker insertion really insertion different DRT, also different DRT, and different DRT way. And thoracoabdominal procedure, such as you have to do the operation of thoracic and abdominal vessel is very different. The last type is the by extension code in Thai DRT. As someone asked, maybe you asked before, if the procedure code one side, right or left, and both sides. Actually, the ICD9 CM, there are no sides, no right or no left. But we can know that we do one side of two sides, just the number. But we don't know which one, left or right. We know that left or right and left and right, left with right. We have another major procedure. This is the cataract extraction. Most patients they think they do only one eye, but in some patients and some hospitals they do both in the same hospital. We want to differentiate these two types. So we have the extension code for this code, and so we have DRT with my measurement. Mean that you do one side, multiple mean that you do both sides.
For the extension for the procedure concerning laterality, is it added in the code or we're just introducing a separate field for it?
It's in the same field, but separate. I will
separate, yes. Thank you.
Okay. And also the primary in some patients, some at the bottom patient, and they have many area of burn. So it can be multiple burn. And also craniotomy anesthesia, multiple craniotomy. Because of craniotomy. And this is the how we use the extension code. This is the ICD9 code. It can be 3 digits or 4 digits. And if you want to tell that you do more than one side or more than one time, so we have two numbers here. The first is for multiplicity, it means that more than one side in the same operation. And this is the second means that the operation first or second or third.
So clarification of my first question, you said it's a separate code. So this is a one code, just extending the code from 3 to 6.
Yes.
Okay.
It's separate from here. With this one. Okay. Two part. Okay.
I thought you said it's a separate. Anyway, that's very good.
And here, so that's you do the cataract operation. This is the cataract, they call emulsification. Okay. 1 T for 1, they call. If you do only one time. If you do sign in one operation, in the first operation, you go like this. Example here, they go in this what two operations. Yeah. This is the first operation, one eye. This is the second operation one eye. So if you do two operation separate, you have to put two codes like this. Yes, this is the first half, this is the second half. It's different from here. Here you do the
same operation.
Okay, clarification on the extension code. That's 2 digits. If it is 1, meaning one side. Okay. The last code is for instances of operation. Okay. The concern is how do we distinguish between this if it's only one side, but it's either left or right?
And the first or second is for this code only, not in the certificate happening time of operation. We count just for this code, and you can see that we have only the number 1 to 9. If more than 9 times, sudden the verification.
We are paying based on the submission of claims. Sometimes they are claiming for operation done first in the left, then later on the right. So it's a different claims for people.
If two operations, you have to put two codes like this.
So this one is Separate days. Separate days. Not the same day.
One procedure, one claims dalawang procedure. Isang claims dalawang procedure.
So the question they have is that in Philippines, sometimes the hospital will do the surgery on the left eye. And then the patient comes back another time in the same year and they get the other eye. But maybe not, maybe it's fraud and they do two claims, but it's same eye. So in PhilHealth, they use the left and right as a way to detect fraud. So if they do two cataract on the same eye, they consider it's fraud. So this way, we don't know if it's fraud. We only know that in the same admission, they have one operation did one eye and a separate operation did a second eye, or the previous one is that one operation did two eyes. So I think it's a different purpose that they're trying to do.
It's different, but for the eye, you cannot do paper extract the same eye two times. Actually, only some multiple operations that the DRG recognize, not all. This is the example. Craniotomy, they have multiple craniotomy and multiple ring procedure and bilateral multiple joint, multiple will deprive, and second gap and multiple deprivation. Not all. So it depends on the data. And at the time when we develop, and not much yet, and we don't have much data to separate the DRG. It is, if you look at the NBC logic, here is multiple craniotomy with the PHIC. And this is the definition for PDC-1PK, multiple craniotomy. We use the symbol that is more than one. So one and more than one. And also here the logic for MDC2, multiple major eye, multiple major and multiple other. And I think that's all for the procedural code in Thailand. If you implement more detail, you must using the DRG, high DRG, Dr. All Time was showing.
No questions.